Okay, everyone, now I'm back in your packet, your handout. Myelomeningocele is what we're going to talk about. You will find this information on page 1461. The reason I am talking about myelomeningocele is because it is the most common form of spina bifida. It's a congenital defect of the spine. We have a round bulging sac filled with fluid and spinal nerves. Sensation and movement completely absent below the level of the lesion. And again, if that lesion is low enough, you're going to see some issues with urinary retention, with overflow incontinence, and also some bowel issues with constipation, impaction, fecal soiling. 90 to 95% of kids with myelomeningocele or infants do develop hydrocephalus. We could also see an associated club foot or hip dysplasia with myelomeningocele. Some of the nursing issues for these kids that we are going to be working through are risk for injury or infection related to rupture of that sac, altered urinary elimination related to urinary retention and overflow incontinence. We'll talk about impaired skin integrity related to immobility. We'll talk about constipation related to fecal incontinence and impaired innervation. And we'll also talk about high risk for sensory perceptual deficits related to possible post-op development of hydrocephalus. Okay, so you can see here our first goal is to prevent the rupture of the sac and possible infection. This is obviously preoperative. Some of our interventions before they go to surgery to get this taken care of is position. Newborns lying on their side with support provided to the area of the myelomeningocele, or we keep them prone. The biggest thing here is we don't want any pressure on that sac, and we don't want any contamination to that sac with urine or stool. No clothing or diapers around that area because we want, again, avoiding pressure on the sac. We want to keep them in a heated isolette or warmer to maintain their body temperature. We do keep the sac covered with sterile, moist, normal saline, non-adherent dressings to prevent drying and cracking. We do need to change those dressings every 2 to 4 hours using strict aseptic technique. We want to make sure we're doing good documentation of, on appearance of the sac. Are there any signs and symptoms of infection, any leaks, any abrasions, any irritations around that area? Now, our next nursing care goal is prevent infection post-op period. Again, we would want to position them either prone or sideline. We can use something that's called a Mylo apron. It's a special type of dressing. And again, it prevents urine or stool from contaminating the suture line. We would give antibiotics, strict aseptic technique for dressing changes, and standard precautions to prevent infections. So really our pre and post-op care is basically the same. Preoperatively, we're caring for the sac so it doesn't rupture and become infected. After surgery, we are maintaining that suture line, keeping that clean and dry. Not so much worried about the pressure on it, but again, we're not putting any tight clothing or diapers, and we're still positioning them the same way. All right, our next intervention, oop, I think I blew by it here, hold on. Okay. Prevent urinary retention and a urinary tract infection. Don't forget, bladder is the nerves that control the bladder. Or that control bladder function are in the sacral area. Same with the bowel and bladder. So a lot of times we do have to worry about these interventions. So if we're preventing urinary retention and preventing a UTI, we want to monitor INO. We want to push extra fluids to make sure those kidneys are flushing. We want to monitor for urinary retention. We want to keep that diaper area clean and free of skin breakdown. We would give antibiotics, and again, we would teach the parents clean, intermittent catheterization. We would also avoid use of latex products and prepare for future urinary diversion procedure. So until we can go in and get it fixed permanently, we're going to do intermittent catheterization. Again, we teach parents clean because that's how they do things at home. Our next set of goals here are to prevent complications of prolonged immobility and associated orthopedic anomalies. Again, we are making sure of our positioning, keep the hips abducted, use positional devices, and again, PT for range of motion. Prevent constipation. Again, we talked about the nerves being affected in that area, in that sacral area. We would begin an early bowel program with diet modifications, regular toilet habits, and they're probably going to be on laxatives. A lot of times in kids we'll use Miralax for functional constipation. You want to monitor for possible hydrocephalus. Biggest thing here is assessing for increased head circumference. I'll talk about hydrocephalus just a little bit more after we look at our evaluation or outcome criteria. Your evaluation is that you maintain the integrity of that sac until surgery is done preoperatively and no infection occurs postoperatively. Adequate patterns of urinary elimination with necessary support. Skin integrity is maintained. Constipation is prevented. Hydrocephaly is prevented via prompt surgical intervention. All right, let me talk a little bit about hydrocephalus. This isn't in your handouts, so just take a listen and then take a look in your book. Hydrocephalus is on page 1387, I believe. Let me flip back to that one. Yep, we've got hydrocephalus on that page. And what hydrocephalus is, the biggest thing is imbalance between rate of production and rate of absorption of cerebrospinal fluid in the brain. Hydrocephalus results when we have excessive cerebrospinal fluid. It causes head growth. That's why we are assessing the head circumference. And depending on age, some of those sutures on the scalp or skull can open up. We would also want to monitor for signs and symptoms of increased intracranial pressure. I'll talk about that as well. I want to keep going with hydrocephalus first. So obviously the head has an increased circumference. In infants, it's greater than 1 inch every month. We see dilated scalp veins, fontanelles, tents, and bulging without head enlargement. We'll also see the setting sun sign. Go ahead in your house when we're done with this, take a look at somebody's eyes. It's when you see their sclera above their iris. We normally don't see any of the sclera except on the sides of our eyes. With the setting sun sign, you will see sclera above and below your iris. Their pupils will be sluggish with an unequal response to light. Their cry will be a shrill, high-pitched cry. This is a late sign or symptom of hydrocephalus. They have persistent neonatal reflexes or hyperactive reflexes. We could see vomiting, irritability, seizures, decreased heart rate, decreased respiratory rate, increased blood pressure, a widened pulse pressure, and increased lethargy. Let's see, on page 1389, there's a box that says clinical manifestations of hydrocephalus. You will see the list of all of those things I just listed off for you. And then I have 1356 in my notes. Let me get to 1356. I know there's a lot of hopping around in this one, sorry. I should have marked my pages better. 1356, yep, it is the clinical manifestations of increased intracranial pressure in infants and children. And we will refer back to this chart when we start talking about other disorders coming up in the lecture.